Hi, it's a pleasure to be with you today. My name is Ricardo Gonzalez. I'm a urologist at Houston Methodist Hospital, and I was asked to speak with you about minimally invasive surgical technologies or MIST procedures. We're going to focus on the three FDA available ones, Urolift, Rezum, and Itin. I'm an associate professor of urology at Weill Cornell and Texas A&M down in Houston Methodist Hospital. My disclosures include relationships with Boston Scientific as a consultant, investigator, and instructor. And I was an investigator for Meditate, which is now the Itin device. So when we talk about MIST procedures, the presentation will focus on the following. What exactly are they? When do we consider these procedures? In context of the AUA guidelines, we're going to talk about an index patient. We're going to look at each of these treatments and available long-term data. So for Rezum and Urolift, we have 5-year data. For Itin, we have 3-year data. We'll briefly talk on cost and accessibility concerns, and then how we can decide between medication, MIST procedures, and surgeries. So when we look at Bph treatment alternatives, you have to balance risk with benefit. We know that medications are relatively low risk, but for a patient in retention, it might not be enough. So depending on the benefit we're trying to get and what risk the patient is willing to accept, we make decisions between these treatments. On the opposite extreme, we have open prostatectomy, which for a patient with a 200-gram prostate who's in urinary retention, it might have a lot of benefit, but it does have more risks of a longer hospital stay, longer time with a catheter, more bleeding and transfusion risks. We know that TURP, laser vaporization and enucleation are all options that are safer than open prostatectomy for the most part. But what we're speaking about today is MIST procedures, which are procedures that sit somewhere between medicines and surgeries that right now during a pandemic of COVID, really it's of benefit to consider procedures that we can do in the office or under local anesthesia as outpatient. So we're going to focus on 3 of those today. Urolift, which is the prostatic urethral lift procedure, Rezum, which is a convective steam vaporization of the prostate, and then Itin, which is an implantable temporary nitinol device. Aquablation, which is also new, is not considered a MIST, and that would be in the surgical column. So in terms of the AUA guidelines that were updated in 2018 and 2019, there were new recommendations that were a bit more specific on who to offer what treatment. And we need to not only know the size of the prostate, but categorize the patient to small, average, or large, know if there's intravesical protrusion. And the AUA committee made a recommendation that eligible men who would like to preserve ejaculation and have BPH should be offered something like Urolift or Rezum if they are candidates. In patients that are higher risk or anticoagulated, lasers are the preferred treatment. So let's just say we have a man with a 30 to 80 milliliter prostate, wants to preserve ejaculation, is not in retention, perhaps wants an office-based procedure under local anesthesia, wants something fast. These are the options that are FDA available. We have convective steam ablation, which is Rezum, prostatic urethral lift procedure, which is Urolift, and Itin placement. So let's think of an index patient of Robert, who's a 68-year-old man with lower urinary tract symptoms due to BPH. He has an elevated PSA in the past of 4.8, negative transrectal biopsy. Prostate volume was 60 milliliters. Symptom score is severe with a score of 25. A prior episode of urinary retention that was precipitated by hernia surgery and has since resolved. He's on tamsulosin, doing okay. He would like to be better, and he wants to maximize his sexual function. He would like to stop a medication. So for this gentleman, basically, we need to counsel him on his options between MIST and surgery. Some of the advantage of MIST procedures, office-based, preserve ejaculation, but some of the benefits of surgery are that we can debulk and remove more tissue, which makes them more durable and gives you a greater impact on symptom score reduction. I'm going to go through this quickly because we only have 15 minutes, but Urolift what is it? It's a permanent transprostatic tissue retractor. You're not removing or extracting tissue from the body. You're using these implants to retract the lateral lobes and pin them out of the way to help the patients urinate better. So you pass a needle through the capsule of the prostate. You put you release a nitinol anchor. You tether it to a polypropylene suture, and then you have a luminol stainless steel tab that you place and keeps that channel open. And what you're trying to do is create an anterior urethral channel, as you can see in this lower right-hand photo. So you're tethering the superior aspect of your lateral lobes to the side to facilitate urination. What's the data? So Urolift has a very mature bibliography. The most important study I'd like to cover is the LIFT study, a randomized controlled trial between sham and Urolift out to 5 years with very narrowly selected patients of 30 to 80 grams without intravesical median lobes. You can see in patients that respond, the IPSS symptoms improve. And if you respond, you continue to respond out to 5 years. And that is something that you also notice with improvement in flow rate. The retreatment rate at 5 years is 13.6%, which means that a little under 14% of patients at 5 years proceeded to either have additional treatments, either more implants, or proceeding to something like TURP or laser vaporization. Remember that the men in the study were not in retention and did not have median lobes. You have the side effects you would expect with all of the things we're going to talk about today: dysuria, hematuria. Unique to Urolift is you can have a little pelvic pain that resolves in 10 to 14 days, and that pain is independent of urination. Something unique to this goes away with anti-inflammatories. What's fascinating and excellent is there's zero incidence of sustained ejaculatory or erectile dysfunction. So you can see down here in this bottom square that there was no de novo erectile dysfunction or ejaculatory dysfunction. Let's talk about Rezum. This is a steam injection into the prostate. Here's a little video that explains the procedure a little more clearly. So you pass the device transurethral. This can be done under local anesthesia. You advance a flexible needle into the adenoma, into the transition zone, and you do a 9-second injection of steam. The steam is created with radio frequency in the handle that converts water to vapor at the tip of the needle. Every 1 centimeter of prostate is treated along the length of the prostatic urethra with steam. And then over the next 1 to 3 months, you have absorption of that tissue with an improvement in flow. As you can imagine, symptoms would worsen before they improve. So for this procedure, I keep a catheter 1 night for every 2 injections. So the average amount of time that a patient has a catheter after the procedure is 1 to 3 days, 1 to 3 nights. So here's an example of a gentleman who had a 52 cc prostate with 3 treatments done on the right, 4 on the left, and 2 in the middle lobe. 6 months later, you can start to see resolution of that tissue with improvement in symptoms. But what's the 5-year data? Very similar randomized control study done, very similar to the LIFT study for Urolift, except these patients who had a median lobe were not excluded. You can see that the symptom scores also improve and maintain their improvement out to 5 years. The flow rate improves. You can see that there's a dip here at year 3 in flow rate. I will clarify that if you separate the ones that had a median lobe that was not treated, that accounts for the decrease out at 3 years. But if you do treat the median lobe with Rezum in a patient who has obstruction by the median lobe, the symptoms improve and the flow rate is more durable. Quality of life improves and is sustained out to 5 years. Dysuria, hematuria. You'll see this theme of urgency, frequency, and transient worsening of these symptoms initially before an improvement. The risk of ejaculatory dysfunction is very low, about 6%, with no de novo erectile dysfunction. Here's the MSHQ ejaculatory function domain on the questionnaire, showing that really no change in the quality of the orgasm as perceived by the patient. If a patient has intravesical protrusion, in the study, they were included, but the investigator had the option to treat or not treat the median lobe. You can see in the blue line, if the investigator treated a median lobe, the sustained improvement in flow rate is better than the green line, which represents men who had an intravesical or obstructing median lobe, where the investigator did not feel comfortable treating the median lobe. Lesson being, to get a good response with Rezum on flow rate over time in a patient with a median lobe, you have to treat not only lateral lobes, you have to treat the median lobe. All right, let's talk about, this is not a head-to-head comparison, but Rezum and Urolift had very, very similar pivotal studies out to 5 years. Some differences are Urolift excluded the median lobe, Rezum did not. Otherwise, the pivotal study, the ages were very similar. Prostate volume was similar, around 45 milliliters for both. Symptom scores were severe at 22 for both groups. But here's just one of the differences that I think is important to point out, is that if you look at the freedom from reoperation or freedom from having to take medications, there's differences at 5 years. And this is, again, is not a head-to-head study, but at 5 years, Rezum patients, the risk of needing an operation is 4.4%. So that means that 95% of men are not having another operation for their BPH symptoms in these well-selected men. 85% are not on medicines. So that means 15.5% do have to resume medicines at 5 years. Compared to Urolift, you can see that it's almost a 14% surgical reintervention rate at year 5, and 24% of patients have resumed medicine. So durability appears to be a little bit better for Rezum, and I think a head-to-head study is absolutely indicated. Let's talk about Itind now. What is Itind? This is a newer treatment, FDA approved February 2020, right before the pandemic. So it's, I think, a little slower on the launch, but it's an implantable temporary nitinol device. So it looks like a stone basket, but with greater radial pressure. And it's positioned within the prostate. I'll show you a video of how it works, but the purported mechanism is that we create ischemic incisions at 12, 7 o'clock, and 5 o'clock, which act like a TUIP procedure, transurethral incision of the prostate, almost like in Spanish, it's a prostatectomy. So the motto is leave nothing behind but the results. So the company likes the idea of this is not a permanent implant. Here's an excellent little video I will try to forward for time's sake. So that is not a pink cobra that represents a penis, urethra, and prostate. And you introduce a scope into the bladder, which will act as a sheath through which we will pass a device that it goes in like a wire, and we expand it in the bladder. So it opens the way you would expect a stone basket to open. You rotate it so you position the 12 o'clock strut at the 12 o'clock position, and then you pull it into the prostate fossa and position it between the sphincter and the bladder neck, such that that little tongue here that you see that has like a downward little tongue sits inside of the bladder neck. And you do that with direct visualization. So you pull the device into the prostate fossa so that this metal tongue sits inside of the bladder neck. That prevents migration into the bladder that happened with earlier versions of this device. You release a knot and remove the sheath that is over a string that facilitates removal. What I'd like you to focus on now is this little picture on the bottom right-hand corner, and it shows how the device causes these ischemic incisions as it expands over the next 5 to 7 days. The device is then extracted in the office under local anesthesia 5 to 7 days later. The patient has never required a Foley catheter. So one of the nice things about this is there's no need for a catheter to achieve the same effect. This is a retrieval procedure which you pass. It's basically a blunt-ended catheter that is open over the wire, and you retract the device into the sheath and remove the sheath. So what are some of the trials here? MT01 represents a first-generation device which had been improved. So MT03 and the other studies have all been with the next generation device that has this tongue that prevents migration. We were part of this, the IDE here for the FDA study, the pivotal study in the US, which was 185 patients selected so that their prostate was 25 to 75 mLs in size. Median lobes were not excluded, but there's a patient selection study that is trending towards favoring, using this for men who do not have intravesical median lobes. You can see that there's a general improvement with symptom scores. The yellow line represents the first generation device, which has less of a durability out to 3 years. The flow rate, same thing. If you compare this yellow line at 3 years, that's MT01 compared to MT02 study 3-year data. The newer device has better durability on flow rate. So we'll see how this evolves over time. The nice thing is retention risk is low. It's about 10%, similar side effects as the other devices we discussed. The nice thing is this as well does not compromise any sexual function with no de novo erectile dysfunction and no ejaculatory dysfunction. In terms of cost, this is just US data looking at cost and symptom scores after 2 years of treatment. Where you want to be is with low symptoms and lower cost. TURP and PVP are very similar on this scale. You can see the difference between Urolift and Rezum. The symptom scores are between 10 and 12, but there's a big cost difference between those two. I believe Itind is priced somewhere in between Urolift and Rezum. So this is something we just have to keep in mind and watch over time. Take-home messages is, in general, think about efficacy for procedures when you're counseling a patient. If they need surgery and they need a larger reduction in IPSS, perhaps a MIS procedure is not what they need, but rather a surgical procedure. These are not head-to-head studies, but if you look in general, a MIS procedure will reduce the IPSS score between 7 and 11 points, and a flow rate improvement that is modest between 3 and 4 milliliters per second. Surgeries, including laser surgeries, TURP, aquablation, HOLEP, get you a symptom score reduction of over 14 points and a better improvement in your flow rate of over 12 points. So to summarize, MIS procedures are for patients maybe who don't want to take medicines. The medicines still work, but they don't like the idea of taking them. They're not in retention. They don't have an indication for surgery. They want to preserve sexual health. Surgical patients, if medicines are failing, think surgery. If patients are in retention, stones, if they're bleeding, if they're in renal failure, consider that. But you have to counsel them on their sexual risks and ejaculatory risks. Patients who are anticoagulated still prefer laser therapies. So the conclusions, you can expect improvements in symptoms with these procedures. They are durable in well-selected men. So men without median lobes for like Itind and maybe Urolift. And retreatment risk is somewhere between 4.4% and 15% at 5 years. So counseling is important for these well-selected men. If these men want to preserve sexual function, consider these. During a pandemic, it's good to have options that can be done under local anesthesia with minimal sedation. And really, the side effects are not serious. It's not likely to require, hospitalization or acute surgery, although some of those have been reported. And then so the conclusions, men have options. One shoe does not fit every foot. And there may be a role for MIS. This is a controversial statement, like Urolift, Rezum, and Itin as first-line therapies in well-chosen men. Maybe we don't have to put people on life sentences of medications. Thank you for having me. And I apologize if this is a little bit long.